Can I have my slides, please?
Can I have the other? Yeah, please. There you are.
Yeah. So let's talk about preoperative evaluation in cases of pediatric cataract. As we know, a comprehensive preoperative workup is the cornerstone for achieving optimal postoperative outcomes. So approaching a child presenting to us with a cataract, first obviously we have to start with a detailed history taking, followed by assessment of the presenting visual acuity. Then we move on to the systemic evaluation of the kid, look at the ocular examination, and finally do a biometry and required ancillary investigations. So when the parents bring us a child with a cataract, some of the chief complaints that they can bring it with is the presence of a white reflex, the complaint of closing eyelids or squeezing the eyelids in the presence of bright light, bringing objects closer to the eyes for viewing them, abnormal eye movements, or the complaint of rubbing of their eyes. So when the parents bring their child with these chief complaints, we have to look at several factors. First of all, the educational status of the parents and how reliable is the history actually. Then we have to look at the detailed sequence of events of what happened and how, and any intervention which was sought previously. Then we have to ask for the significant family history and draw a detailed pedigree assessment to see if there is any familial nature. Then we have to take a detailed birth history, starting from the antenatal history, that is if the mother had any history of fever or rash during pregnancy, if there was any drug or radiation exposure, then going on to the birth events, and finally, postnatally, the immunization status. Then we ask for any food or drug allergy, and then we move on. If a patient's chief complaint is the presence of a white reflex, we have to rule out other major differentials as well. So looking at the anatomical location of the leukocoria, we can have things anterior to the lens, which include a corneal opacity or Peters anomaly. Then we can have lenticular opacities themselves. And finally, posterior segment anomalies, like a retinal detachment, a vitreous hemorrhage, Coats disease, toxocara, or persistent fetal vasculature. Once we have looked at the history, now we move on to assess the visual acuity. And one of the first things that we have to look for is the fixation status of the child. So when we are assessing the fixation, we have to notice where the light reflex is when we shine a torch from a distance. And if it is directly at the center of the pupil, that is central, it implies that there is foveal fixation, which signifies that a good visual outcome can be hoped for.
Magnified, I think. तो ये नहीं डालना चाहिए था मुझे ना. Okay. Yeah.
So a central fixation implying a foveal fixation is a good predictor of good visual outcome. Then we move on to see if the fixation is steady or not, which implies that there is no nystagmus, and then whether it is maintained on a cover-uncover test, which again, the absence of a nystagmus or strabismus implies better outcomes. Now we go on to various modalities of visual acuity assessment. Starting from pre-verbal children, that is infants, we have various techniques available with us, which include Teller's acuity chart, which is square wave gratings and based on the preferential looking principle. Then we have the optokinetic nystagmus drum, which has again gratings, and we see whether the child is able to follow, how fine the gratings the children is able to follow. And finally we have the Catford drum, which has dots of varying sizes, and again we look at the smallest dot which a child is able to follow. In the age group of 1 to 2 years, we have the Cardiff's visual acuity test, which is based on vanishing optotypes. Then we have Worth's ivory ball test, in which ivory colored balls of various sizes are rolled across the floor, and we see the smallest size of the ball that the child is able to follow. And finally we have the Steicar test, that is the screening test for young children and retards. Then in the age group of 2 to 3 years, we have the miniature toy test, the coin test, and the Lee symbols. Again, we are looking at the smallest size of the object that the child is able to follow. In the age group of 3 to 5 years of age, we have the Allen's picture card test and Lipman's HOTV test. And finally, in school-going age of more than 5 years, we can have the same test that we use for adults, namely the Snellen's chart, the tumbling E chart, or Landau's broken ring test. Once we have had some estimation of the presenting visual acuity, we move forward to examining a child, which can be really difficult. And so we have to ensure that the child is positioned comfortably. And for any child, the most comfortable position is the mother's lap or the shoulder. So we ask the mother to take the child on her shoulder and then turn towards us. And then we can start assessing a gross assessment of the of any abnormal facies or any syndromic facies which we might be able to identify. Then before a dilated assessment, we have to look for the pupillary response. A brisk and equal response in both the eyes suggests better outcomes. Then we do a distant direct examination to look at the anterior segment structures, starting from the cornea to look at the presence of any corneal opacity, then looking at the anterior chamber depth, presence of any peripheral anterior synechia or posterior synechia. And finally, we dilate the pupil to look for the presence of the morphology of the cataract that we are looking at and to see how much the pupil dilates. Then we move on to the systemic evaluation of the kid, which is of utmost importance, and this is guided by our history and examination that we have undertaken. So like if a mother gives the history of a presence of any fever or rash during pregnancy, we can suspect any of the torch infections and the torch profile needs to be sent. If the child has history of seizures in the neonatal period or suggestion of a gross developmental delay, a neurology opinion has to be sought. If during our examination we found a non-dilating pupil or posterior synechia or any such feature which suggests a uveitic cataract, then we have to assess for a rheumatology opinion. If the patient has features of a Marfan syndrome or a rubella cataract, then a 2D echo has to take place. And finally, if the morphology of the cataract is something like an oil droplet which we find in galactosemia, the fasting blood sugars and urine for reducing substance has to be sent. Now, there are various syndromes which can be associated with a congenital or developmental cataract. Some of the syndromes which we have come across at our center, which is a JAG1 mutation, in which the associated features are broad nasal bridge and an epicanthus palpebralis, butterfly-shaped vertebrae, lamellar cataract with riders as shown in this image, and a posterior embryotoxon. And these have associated limbal stem cell deficiency. So on impression cytology, we found goblet cells on the cornea. Then Larsen syndrome, which is a collagen 7 synthesis defect, which presents with developmental cataract, patchy alopecia, syndactyly, polydactyly, and low set ears, along with a limping gait as seen in this video. Along with this, on fundus evaluation, there is diffuse chorioretinal degeneration. Fetal valproate syndrome usually presents with a history of valproate intake by the mother during the antenatal period. It has a typical facies of broad forehead with a telecanthus and epicanthal folds and is associated with a total white globular sort of cataract. On fundus evaluation, we can have a normal disc but a diffuse chorioretinal degeneration. Then this was a case of Sickle syndrome, which presented with a microcephalic primordial dwarfism and triangular facies. This is an autosomal recessive condition which presents with bilateral developmental cataracts. Now, once we have looked at the systemic features and we have done a visual acuity assessment along with an ocular examination, we move forward to our operative planning. And again, the cornerstone of an operative planning is the biometry. Now, axial length assessment in these children can be really challenging, and more so because there is a high rapid growth during the initial age. So immersion A scan, although theoretically is more accurate, since it precludes the indentation of the central cornea as seen in contact scans. However, since we cannot ensure proper fixation during an immersion A scan, this is not so much useful in children. So most commonly we do a contact scan method. And when we are doing a contact method, maximum AC depth should be taken so that we have some idea of it going through the fovea. And an axial length of more than 17 mm is preferable for IOL implantation. From axial length, next we go on to keratometry, which is usually done under general anesthesia during our examination under anesthesia using handheld keratometers. However, in children, older children who might cooperate, optical biometry is still the gold standard. Then another predictor of postoperative outcomes is the presenting intraocular pressure, especially more so because pediatric cataract is associated with pre as well as post-op glaucoma. So during an examination under anesthesia, Perkins tonometer to assess the intraocular pressure is of utmost importance. And any factor which predicts the presence of glaucoma, like rubella cataract, uveitic cataract, or a post-traumatic cataract, must be especially watched out for. Next, we move on to ultrasound biomicroscopy, which is an extremely useful tool. It is a non-invasive modality working at high frequencies of 35 to 50 megahertz, thus having lesser penetration. And this can help us in the preoperative assessment of sulcus, such as when is required for a secondary IOL placement. Then the lens thickness and the morphology of the cataract itself, which can help us in planning the surgical steps. The back diameter and the presence of certain features like a posterior polar cataract, a pre-existing posterior capsular defect, or the presence of a persistent fetal vasculature. I'll be showing some images of ultrasound biomicroscopy. For example, this first image is a typical zonular cataract with a central clear zone. Another one in which the cataract is predominantly central with a peripherally clear zone. This is one which has a pre-existing anterior capsular rupture, and we can see the cortical matter protruding into the anterior chamber. This is a case of microspherophakia in which the lens is almost coming into the anterior chamber. And finally, we have one subluxated lens with a posterior lenticonus, as can be seen in this image. Now comes the most important part, which I'll be just touching upon, that is the IOL power estimation. Now we know IOL power prediction is very uncertain in children, and we have conflicting literature published. One thing we can all agree on is IOL is to be implanted in only those eyes which have adequate size, that is axial length more than 17 mm and wide to wide of more than 9 mm. Now, like sir just said, the predicting the IOL power is very difficult, and these various formulae have been described, which sir will be covering in details. So that is all in preoperative assessment. Next, we move on to the surgical steps.
We'll do that. Thank you, Aayush. Can we have the phone switched off, please? Excuse me, sir, red shirt. आपका phone से disturb हो रहा है. Phone बाहर जाके ले लीजिए. बाहर भी ठंडा है. Okay, so once you decided which patient to operate, right? So the cataract, which is significant, I think she's also going to touch upon that. Now we're going to show you how to pick up the patients, how to do it, when to do it, and which ones not to do. And the most important thing here is that till you've done a EUA in a small child, you're not sure what the child is showing you, right? There could be a flat anterior chamber. There could be an anterior capsular bulge which has gone backwards. So if you're smart enough to pick up these things in which you can make out that the lens is going behind the iris, that is an indirect sign that its convexity has lost because it's opened at the back. So now we're doing a study in which we found out that all these patients in which the anterior capsule curvature is lost are actually having posterior capsular defects. So I think she's going to show you a few things on that.